So I think this is kind of where we left off yesterday, right? Okay, so we know that during the period of growth and development during the first trimester is extremely important, right? Because we talked about that yesterday. All those things that are growing and developing during that period of time, you need to make sure that the mother is doing exactly what she's supposed to be doing. And there are certain things called teratogens. Have you ever heard of that big word? What is a teratogen? A teratogen is something that is harmful, a harmful substance. So drugs and alcohol would be considered to be teratogens. They're harmful substances. Okay? Now, some specifics. Let me give you some examples of some things that can occur. Cocaine abuse. Women who abuse cocaine during pregnancy can lead to spontaneous abortion, can lead to preterm labor, can lead to separation of the placenta, and stillbirth. And remember me talking, or I know that I've mentioned this to you at some point, you know, those babies are pitiful. Babies who are born with drugs in their system are just absolutely, if they do survive, are miserable, 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 miserable. And one of the roles of the NICU nurse is to detox them. And you're giving newborns morphine.
That's how you. At Rowan last
week. Did you have
She didn't give it to any of us, but he was on 1 milligram of morphine. The mom was on methadone.
Yeah, exactly. Exactly. And those of you who are at Northeast will be able, I know that they're rotating you through the NICU just to see what's going on in the NICU. And definitely you'll see some drug babies down there. So, very sad situation. All right, tobacco use. Tobacco use can lead to vasoconstriction in the mother. If you're vasoconstricting, what is the baby not getting? Oxygen. Right. Okay. Alcohol abuse is one of the leading causes of mental retardation in a newborn. So those are just some examples.
Do they drug test every mom or only?
Not every mom, if they suspect. Just if they suspect. I don't know, they should. Yeah. But it's not every mom, but definitely has an impact. So those are just some examples of, there are a lot of others. I mean, we could go on and on. And you know, even the mothers who are taking methadone, you're glad because most of them are on methadone because they're weaning themselves from heroin. You know that heroin is one of the biggest drugs right now. There's an increased amount of use of heroin right now. And to get off of heroin, they go on methadone. And so, but methadone has its own problems with newborns. So you still have to wean them off the methadone. So it's just one thing after another. So it's a very sad situation. Okay. We'll do that in just a little bit. Okay, Geraldine Broderick. You know about Geraldine? I'll go ahead and tell you about Geraldine. Geraldine has the world record for the most children delivered at a single birth. The most children delivered at a single birth.
12.
Nope.
24.
9. Good. 9. It was in 1971 in Australia. That's why I got the kangaroo there. She delivered on June 13th, 1971. None of the children, 5 boys and 4 girls, lived for more than 6 days.
Oh my gosh.
It's kind of sad, isn't it?
Wow.
But she does. So I don't know if holding the world record is a consolation or anything to her. But yeah, none of them survived. But you can imagine the stress on the body of the mother carrying 9 fetuses at a time. I mean, you really could not support physically that kind of situation. All right, you should have in your packet a chart that says changes that occur during pregnancy by system. Changes that occur during pregnancy by system. Okay? So go ahead and get that out. Before we start this chart, though, let's talk about what we're getting ready to do with this chart is we're going to talk about the things that occur, the things that change in the mother during pregnancy to her body that you know she's pregnant. Now, this slide right here talks about the 3 types or the 3 categories of signs of pregnancy that we're getting ready to talk about the chart. So the first kind are presumptive signs, and presumptive signs are subjective. So when I say subjective, what does that mean? Okay, the mother feels it. So subjective are those that are felt by the woman. All right, so some examples of those are breast changes, like the tenderness in the breast, nausea and vomiting, urinary frequency, and fatigue. So those are some examples of presumptive signs. Now, when it means presumptive, it doesn't mean, yes, it does mean that it's felt by the mother, but you also can look at it this way. You are presuming that the signs are pregnancy, but they could be from something else, right? They're very, you don't want to say vague signs, but they are, because they go along with other disease processes. So when you're presuming that the signs are pregnancy signs. All right, the second category is probable. Probable signs are objective signs. So probable signs are those that are observed by an examiner. Those that are observed by an examiner. So that would be the physician or the nurse practitioner or whoever is taking care of that mom. Okay? Now, there are some terms or some signs that you need to know that go along with probable signs. And the first one is called Goodell's sign. Goodell's. Goodell's sign. Okay? And Goodell's sign is cervical softening. So when they go for their checkup and the physician goes in and does their little check, they're going to see that the cervix is what we call ripening. Ripening like a melon. Okay? It has to get soft because remember the cervix is going to have to do what? It has to stretch and thin. So it has to soften. So that's cervical softening. Okay. The next sign is Chadwick's sign. Chadwick's sign. Okay? Chadwick's sign is a blue discoloration of the cervix. The cervix changes colors. And then the last sign is Hagar's sign. Hegars. Hagar's sign. And Hagar's sign is a softening. And this is of the isthmus. And I'm going to tell you what that is. I'll make sure I spell it right. The isthmus. The isthmus is the lower uterine segment. So it's the lowest part of the uterus. Okay, so you got three signs: Goodell's, Chadwick's, and Hagar signs. And all of those are what we consider probable signs. Now again, the word probable means that those signs are probably related or due to pregnancy, but things like cervical cancer or uterine cancer can also cause those changes. So now what you've done is you've narrowed the possibilities down. You know, in the presumptive signs, you can have, you know, urinary frequency with a lot of things, or nausea and vomiting with a lot of things. Probable signs, you're narrowing it down to pregnancy plus maybe one or two other things. But probable signs are those observed by the examiner. Other probable signs are a positive serum or urine test, a positive pregnancy test, and the ability to move the fetus by the examiner. That's a fancy term, like they can actually palpate it and feel it.
These are still probable?
These are still probable. Because again, if you've got a tumor in there, it could be. All right, now.
That ability to move fetus.
The fetus by the examiner. So that the physician is able to actually palpate the fetal, the form of a fetus or the form of something and move it. All right, now, positive signs. Positive signs are there's nothing else it can possibly be. Positive signs. Positive signs of pregnancy are those that are attributed to a fetus. It is only a fetus that it can possibly be. Visualization. Of course, you know, you do your ultrasound and you see the fetus on the screen. That's the only thing it could be, right? The fetus. Fetal heart tones. Fetal heart tones are positive signs. Okay, so those are signs that are attributed to the fetus itself. You can see it and you can hear it. Okay? Does that make sense how they start to occur? So, of course, presumptive signs occur the earliest and positive signs occur the latest when you're looking at the different types of signs. Okay. So let's look at your chart now. Okay? We're going to go through each of these different systems and talk about all the different wonderful things that occur when you're pregnant. Those of you who have not had a baby yet may never want to get pregnant after we talk about this. Okay? All right, and this picture is a picture I put in your PowerPoint. I like it because it gives you kind of an overview of what happens to the mother during pregnancy. The first thing that we want to talk about is the uterus itself. Okay, so the uterus itself. So that one is right here, the uterus itself. Okay, now listen to what I'm saying, and then you can write it shorthand if you want to write it shorthand. Remember those 4 hormones that we talked about? The HCG, the HCS, the estrogen, and the progesterone. Okay? Estrogen and progesterone cause the uterus to grow. It causes the uterus to grow. It develops new fibers. And the fancy term for that you've probably heard of before is hyperplasia. You know those? You know that word? Hyperplasia, new fibers. And hypertrophy means that it's in the existing fibers are enlarging. Because remember, we've got to be able to stretch to accommodate a growing fetus. So those 2 hormones, estrogen and progesterone, cause the uterus to grow by hyperplasia, new fibers, and hypertrophy, enlargement of the fibers. Now, at 10 to 12 weeks, the top of the uterus, which was called the fundus, remember we talked about that during postpartum assessment, right? The top of the uterus, or the fundus, can be felt above the symphysis pubis. Now, where is that? Down low? Okay, so it has grown out of the space, of the pelvic space. Now, a lot of you have asked me, since we did our postpartum assessment, if you can always palpate the top of your uterus, and no, you cannot. Your uterus is very tiny, very, very tiny, about the size of an almond. So it sits inside the pelvis, and you can't feel it unless you're pregnant. So the top of your uterus actually grows to accommodate that big baby, that big alien that's growing inside of you. So at 10 to 12 weeks, it has enlarged enough that you can now feel it above the symphysis pubis. So if you know where the symphysis pubis is, that's pretty low, right? That tells you how small it is when you're not pregnant. Okay? By 20 to 22 weeks, it's at the level of the umbilicus, at the level of the belly button. 20 to 22 weeks, it's stretched to the umbilicus. At term, it reaches the xiphoid process, which is why at term it is very difficult to breathe, right, to take deep breaths. And think of all of the organs it's pushed out of its way while it's been increasing. That's why everything, if you can imagine it, as that uterus is growing up, your intestines are going up. Everything's compressing. You know, the liver and the spleen are pushed out of the way. Kidneys are kind of compressed. Everything's because it's trying to accommodate this uterus. So that's why we have a lot of other issues at the same time. Okay? All right? Contractility. Braxton Hicks began around 4 months. Braxton Hicks began around 4 months. Okay? These are painless. They should be. Now they're uncomfortable, but there's a difference between Braxton Hicks and true contractions. Those of you who've been pregnant know that there's a big difference. Braxton Hicks should be painless, and they're irregular too. The purpose of Braxton Hicks is to increase blood flow and grow the uterus to accommodate this baby. Okay. So they're important. They're very, very important. The difference between Braxton Hicks and true contractions is that if you walk or exercise, they go away. They should go away. And we're going to talk about later, we're going to talk about true labor versus false labor. And true labor, they don't go away. They continue on and on and on and on. All right, the cervix. Cervix. Now, we talked about Goodell's sign, didn't we? About softening. It gets softer. Now, a cervix, those of you who haven't had me yet in SIM, a cervix looks like a round donut. Looks something like this. Okay? In a woman who has never had a child, who has never been pregnant, or a woman who has never dilated, okay? If you've been pregnant and you never dilated, like you went and had an immediate C-section, you never went through labor and the dilation and all that, your cervix, it looks still like this, okay? After delivery, after dilation and delivery of a baby, it becomes flat. It looks like you stepped on the donut. Okay? It's flat. It's this kind of jagged, flat, out of shape line. It's kind of pitiful looking, like this. It's squished. Okay? Now, I had a C-section with Ben. And it was a planned C-section because he was breech. However, me thinking I knew everything, waited too long to go. I went for my checkup, and I had been having some pains at home, but I thought it was just being uncomfortable. You know, and I was working through them and cleaning the bathroom and doing all this stuff. And then when I went for my checkup, she was so mad at me because I had let myself dilate to 3 centimeters. And so even though I had a section and never went through labor, never labored before my section, I still dilated. So my cervix looks like this. Okay? I'm assuming. I've never seen it, but I'm assuming this. Okay? So you can always ask your doctor, except for the men, that when you go for your pap smear, you know, they have those mirrors. You can ask them to see if you really are curious. Okay? There's absolutely nothing wrong with that. You know, just say, I want to see what I just want to see what a cervix looks like. A real cervix looks like. Those of you who've been to the health department, they may let you in on some pap smears. You can see cervixes. Yeah. Did you get to see some? Lakeisha got to see some.
I saw a cervix.
Yeah. Did you really? At the health department?
At the health department. You're a liar.
They let you in?
I was with the doctor.
So you really did get to see one?
I got to see.
Are you lying?
It was a head to assessment.
Is he lying? I can't tell if he's lying or not.
I promised it.
Why would he say
You're a liar. Read my discussion.
I still don't trust you. How are you going to tell me? So anyway, but it's a good time to see it. It's interesting, and you know, it's not big. It's small. The tip of the cervix is small. But this little center part is where they go in to do your pap smear. You know, they take that little Q-tip thing after they've stretched you to kingdom come, and they dab in there to get the cervical cells. You know, I say that every year. I say, go to your doctor and have them show you your cervix and all that. And I never have had anybody that has taken me up on that. Do it, Jennifer's going to do it.
Don't they offer you a mirror when you're having a baby too?
Heck yeah. Did y'all ever see Fried Green Tomatoes? Mm-hmm. When they went to when she went to that support group and they all had the mirror and everything, and
I love them.
That's such a funny movie.
It is.
Yeah, you need to watch it. Yeah, that's a funny movie. Okay. The vagina. The vagina. All right, those wonderful hormones that I was talking about earlier cause the mucosa of the vagina to thicken. Yep. Okay. The mucosa of the vagina thickens. The length of the vagina becomes longer. They call it the vaginal vault. Like a vault you would keep your money in. Taylor's back there like this. I wish every one of you could just sit up here and look at your faces. It is so funny to watch. Okay. So the vaginal vault lengthens. Now, there is that mucosa starts, that mucus that I told you thickens. It starts to become a discharge. It's leukorrhea. Has everybody ever heard of that word, leukorrhea? A white discharge. And it drops down and it feels the tip of the cervix right here. Okay, bless you. Okay, feels the tip of the cervix. You know what that's called? The mucus plug. The mucus plug. You're saying, hey, how are you feeling? I haven't seen you since you about had a heart attack in the lab. Are you?
Okay, what'd she say? It says mucosa starts to have discharge, leukorrhea, and it feels what?
It feels the tip of the cervix. I don't know if that meant like feel.
No,
feel
it feels
pouring
it
a
up.
cup. Okay. So, what the hell is that called?
Mucus plug. I don't know that I spelled it right.
What is that logo word you said?
Leukorrhea, Leukorrhea. Leukorrhea. And it's just that white discharge, that white mucus. Leukh. Orrrhea.
You said that was a mucus plug?
It's that mucus. It's the mucus plug. Now, you know what that mucus plug is called? The fancy word for a mucus plug, so you can throw this around and look like you're real intelligent. The fancy word for a mucus plug is operculum. I'm going to write it down. Operculum. Operculum. So you don't have to say mucus plug. I mean, that sounds nasty anyway. It looks nasty, so, you know. What is the purpose, though, of that? Yes, it prevents bacteria from getting inside. So it seals it off. Is what it's doing. It's sealing it off. So that none of the bacteria can get up into the cervical canal, up into the uterus, and infect the baby. So it's very, very important. That operculum is very, very, very important. Acts as a barrier. Now, right before delivery, women lose that mucus plug. It falls out. And if you've never really seen what it looks like you've sneezed in your hand. It's blood tinged, and it's just stringy mucus is what it looks like.
Jelly.
It's stringy mucus. I don't know of another way to describe it. Huh? It does. It looks like a big loogie. It does. It really does. And and it's one of those things. Have you ever wiped your kids' noses and it just strings out and you just keep wiping it? Y'all have all done that with your kids. Y'all don't act like it grosses you out. Y'all are nurses. Right? But it looks just like that. That's exactly what it looks like. So it's very thick, but it was very, very important during pregnancy. You definitely want that mucus plug, and you don't want to lose it too soon. Because if you lose it too soon, then we're in trouble. We're in big trouble. All right, the breast. The breasts become full, very sensitive, very heavy as early as 6 weeks. Some women report that breast sensitivity much earlier than 6 weeks. In women who have never been pregnant before, it takes longer sometimes for them to notice changes. Okay, but as early as 6 weeks. The nipples and the areola become pigmented, much more pigmented. They become darker. And the nipples become erectile. Why? Because they're preparing for breastfeeding. They're preparing for breastfeeding. They become more erectile. All right, mammary glands, M-A-M-M-A-R-Y, mammary glands, grow during the 2nd and 3rd trimester. The 2nd and 3rd trimester. But women don't start to lactate until after birth, when those hormones drop out the bottom. Remember, I talked about all those hormones that are supporting the pregnancy. After the delivery of the baby, there is no placenta anymore, right? The placenta is born. So once those hormones are gone, specifically in this case the estrogen, once it drops out the bottom, lactation occurs. Don't you think this is miraculous? I think this is an amazing process. I really do. Okay? Does everybody get that? All right, the cardiac system. The cardiac system. Now, remember, we have to support another human being. And even though we talked about yesterday, how many calories do we really only need? 300. Remember that pitiful amount? Our bodies still have to be able to support this growing fetus. So the heart is no exception. And so what happens is that the heart hypertrophies. So it enlarges to accommodate an increased blood volume. Now, who would that be dangerous for? Women who already have a heart condition. And we're going to mention problems during pregnancy and probably Monday. And those women are a big concern. Women who have heart problems going into pregnancy, that's a problem. Because that slight, even though it's slight, that hypertrophy can really cause a strain on their heart. But we have to have an increased blood volume to support this child. Okay? Do you remember when we were talking about, when we did assessment, and I talked about those extra heart sounds? Remember we talked about Kentucky and Tennessee and all that stuff? That extra heart sound, that S3 and S4, can be heard in pregnancy. You can actually hear that in pregnancy. And it's because of this increased volume. You know, it's unusual to hear it in anybody else except athletes or children. But in pregnant women, you can hear it. And it's because of that increased blood volume. So you hear it, that extra heart sound, that extra... And you may even hear a small murmur just because there's so much blood trying to circulate through those valves. Much more than usual. What do you think happens to the blood pressure? You would think it actually drops. It actually drops during the first and second trimester. And then it increases during the third. What are you doing? You look like a puppy dog rubbing your... Now, another thing that can cause those heart sounds to be more audible is the fact that as that pregnancy grows, remember it increases up to the xiphoid process, remember that? So we talked about how it's pushing all those organs. It's going to push the heart too. It's going to push the diaphragm up against the heart. So it kind of squishes it. Everything's squished and it stretches. Did you know that? That your chest, if you measured your chest size before pregnancy and then during pregnancy, everything goes this way. Like your ribs increase, like your ribs stretch out. You actually get wider this way because something has to happen, right?
Right.
Yeah. Exactly. All right, there is a problem with the heart that every woman has to be very careful about, even those women who don't have heart problems. It's called Vena cava syndrome. What happens is that what they tell you during pregnancy is that you cannot lie on your back as the baby increases in size, because the weight of that baby and the weight of that gravid uterus lying on the vena cava is going to cause your blood pressure to bottom out and you pass out, you faint. Plus the fact that the blood's not getting to the baby. It's compressing it, so you're not getting enough blood flow. So what they tell you is as the baby grows and develops, you should lay on your side. And so those women who are back sleepers have a hard time. I used to sleep on my stomach before I got pregnant with Ben, and now I cannot. It just doesn't feel right. But you can't lay on your back because of that Vena cava syndrome. Okay. This is how much blood volume increases. Remember I said it increases? It increases 40 to 50% above your pre-pregnancy level. That's a lot of blood. But remember, we're having to support someone else at the same time. 40 to 50% above pre-pregnancy levels. That's a lot of blood. So did everybody get the Vena cava syndrome? Everybody understand that? Did you tell them not to sleep on their back? Okay, respiratory. Estrogen, and another substance that we're going to talk about again in a minute called Relaxin, and that kind of tells you what it's for. Whoever named that was very smart. Okay, estrogen and a substance called hormone called Relaxin soften the ligaments all over the body. Remember we talked about the fact that your shoe size can increase? And I think I mentioned that yesterday about Relaxin and how it softens everything. Yeah. So, when it softens those ligaments, it helps the chest to be able to expand out to accommodate everything being compressed up into the chest cavity. They say that the diaphragm, and this doesn't sound like much, but when you think about the inside of the body and how everything is kind of laid out, they say that the diaphragm can be displaced as much as 4 centimeters. So if you think about 4 centimeters, I mean, you know, it's about that long, maybe. I mean, it's a lot inside your body because everything's being compressed, everything's being shifted up. So the chest wall has to go out, and the way it does that is because the estrogen and the relaxin help to relax those ligaments. Something that a lot of people complain about during pregnancy is having a stuffy nose, nasal stuffiness, and some women also complain of nosebleeds, have a lot of nosebleeds, and that is due to increased vascular congestion. Remember all that blood flow I just talked about? When you've got so much blood flow, what does it cause to do to the vessels? Kind of an edematous. It stretches them and they cause an edema type situation. So do they let you take anything? No, you have to suffer through it. Suffer through the stuffy nose and the nosebleeds and all that mess. Okay? All right, the kidneys. This is renal. All right, the renal pelvis and the ureters dilate and elongate. The renal pelvis and the ureters dilate and elongate. So what is that allowing them to do? Hold more urine. It allows you to hold more urine. What is a problem though with that? UTI. If you hold more urine, it's sitting there more. So women who are pregnant can have frequent urinary tract infections, especially if you are prone to urinary tract infections. You know, some people are just more prone to them than others, and so they can actually get more urinary tract infections during pregnancy because all of that urine is sitting there. What else might we have to worry about with all that urine sitting there in the kidneys and the bladder? It's just sitting there. It's just static. Huh? Well, we talk about kidney infections, urinary tract infections, stones. Remember, we're in the stone belt, right? We're in the kidney stone belt. Stones are a problem. And another problem is that you can't really do much about it during this time. You can't go through lithotripsy and surgery and all that stuff, so you really kind of have to suffer with them, unfortunately. But stones become a problem because it's just sitting there, just building up those little stones. So if you're more prone to kidney stones, then during pregnancy it's going to be a problem. All right, now, what happens to urinary frequency during the early stages? It increases, right? You have to go to the bathroom more. That's one of those signs. Would that be presumptive, probable, or positive? Presumptive. It would be presumptive because can you have urinary frequency with something else? Right. With a lot of other problems. So it was a presumptive sign. So urinary frequency. Now, as that baby is growing, as it lifts out of the pelvis, okay, so remember, at 10 to 12 weeks, where do we find it? Right above the symphysis pubis, right? Right above the symphysis pubis. And then as it's growing, and when it gets to about the umbilicus, then all of a sudden you don't have to go to the bathroom all the time anymore because it's not sitting on top of that bladder. Now that baby is growing and it's floating around up here as opposed to everything being sitting down on that bladder. Okay, so now you don't have to go to the bathroom as much. However, late in the third trimester, when that baby is when we're getting ready to start labor, the baby drops again. And so it goes from urinary frequency to all relief, and then urinary frequency again because that baby has dropped down. I do want to say something else too during this phase. A lot of women complain of edema in their legs and their feet. They do not prescribe Lasix or any of those medications to get rid of the fluid. It's just the fact that there's increased blood flow, it's dilating the veins, you're able to hold urine more, so they may not be going to the bathroom as much. If they increase the amount of time that they're going to the bathroom, and you really should tell these pregnant women, you need to go to the bathroom on a regular basis, even if you don't feel like it, because all that urine is sitting in there. Empty your bladder, lay down and put your feet up. That fluid will re-enter the circulation again. So they don't prescribe any kind of diuretic. Unless, of course, you have a condition that would need a diuretic. Okay. The skin, integumentary. We have increased skin thickness in subdermal fat. Why is that? Insulation, it protects the baby, keeps it at a perfect 98.6 degree temperature. We have hyperpigmentation of the skin. Hyperpigmentation. This is the one time that you're going to have beautiful fingernails, because your nails grow, your hair grows. Especially taking prenatal vitamins. You know, those, when you take prenatal vitamins along with all this other stuff that's going on, it really does help. So, strengthens everything. However, you sweat a lot because we have accelerated sweat activity, sweat gland activity. Okay. Some terms. There's striae gravidarum. Yep, those wonderful stretch marks. And I don't care how much cocoa butter you slather on your body, it ain't going to go away. Maybe help, but it's not going to take them totally away. Striae are those little fragile cutaneous tissues that as the skin is stretching, they break. Those fibers break loose. Okay? And they cause stretch marks. And you can have them anywhere. You can have them on the sides of your breasts as your breast size increase, on your hips, on your stomach, on your thighs. Okay? Anybody have anywhere different? Your butt. Okay. I like that. Have you ever seen on Facebook that it used to be put up all the time, and it was it's like a tiger, and it talks about a woman with her stripes and how ferocious she is and how powerful she is. And I think that's true. You know, it's like a mark of some success or something. Okay, that's what we can look at least. All right, chloasma. Chloasma. is they call it the mask of pregnancy. Okay, remember I talked about yesterday, we talked about that there are some definite changes that occur, and everybody says you glow. Chloasma is one of those things. It's hyperpigmentation of the skin. So you've got it in the cheeks and the forehead and the nose, and it's got this kind of red glow about you. So a lot of people call it the mask of pregnancy. And then the last one for the skin is the Linea Nigra. It is a line, a darkened line that marks, it goes from the top, or the syphilis pubis to the top of the fundus. And so it's a line that actually extends on your skin, and they don't go away either. Did yours go away? Some fade, but I've seen some that have not gone away. So, but the Linea Nigra.
My little baby had that. Want to stay on the little baby?
Should he?
He had a little one, didn't he?
Did he?
He was a Hispanic baby. Because Miss Chandler even pointed it out to us.
I've never seen that stand. Interesting. Did she do her?
Drop out first.
Yeah. Scares everybody. Okay, so it goes from the syphilis pubis to the top of the fundus, midline. Don't all these things sound wonderful? You're falling apart. You can't breathe. You're sweating all the time. All this, your skin stretches.
What causes the line?
Huh?
What causes
The line. It's just a hormonal thing.
The symphysis pubis to the top of the fundus.
Everybody has it. Some are more visible than others. I could not see mine well at all, but I'm also very pale skinned too. But some people can see theirs more than others. But everybody has it. Okay? Let's do musculoskeletal, and then you can take a break. Remember when we were doing assessment and we talked about the different spinal positions? We talked about kyphosis in the old people, and scoliosis is the curve. What's the one for pregnant women? Lordosis. So on top of all this other mess that's going on, you have to waddle too, okay? Lordosis is a curve of the spine. Do you know why we do that? It's balance. It's maintaining balance. Our body is instinctively maintaining balance, because if we didn't do this when we were pregnant, we'd fall over. We'd fall forward because of the weight of this baby. Okay, so lordosis. Remember we talked about relaxin a minute ago? Not only is it causing our ligaments up here to stretch, but it's causing the ligaments and the joints in the pelvis to relax, so that it will stretch to accommodate this growing baby. And a lot of women complain of that pain. You can feel it when you sit down. You feel your pelvis kind of feeling like it's stretching out. Like, you didn't feel that, Jennifer? Oh, it was miserable. I remember feeling that. Anybody else feel the pelvis stretching? Whew, Lord. It's pain. Jennifer's like, you didn't have any of this stuff? You had easy pregnancy. You what? Yeah. Okay. Now, there's another wonderful thing that could occur. It usually only occurs in women who are overweight or who have very poor muscle tone. But there's a condition, and they used to have a picture of it in your book. I hope they still do. It's called diastasis recti. Diastasis recti. I'm writing it up here. Get my marker. More common in women who have poor muscle tone. What happens is the abdominal muscles pull apart. They break apart. So if you've got a nice muscle, fibrous muscle here, it separates. And so they have very poor muscle tone, and that there's nothing you can do about that. They can do surgery if it is severe enough after the baby's born to put some of this back together. Some women wear corsets or to try to get it to stay in place. But those muscles, what happens is those muscles just pull apart in the abdomen. They stretch out. It is not painful. It is not painful. No.
So do they grow back after?
No. They never go back. That's what I'm saying. The only thing you can do if it's bad enough is surgery, or you can have plastic surgery to get it looking better, but no. Okay? All right, take a break. Where were we? Neurological. There's really not a whole lot known about what happens neurologically when you're pregnant. We do know that a lot of women who have a history of migraines or tension headaches complain about those headaches getting worse. And some women will actually faint. Has anybody ever had that problem? Anybody ever had that problem? And what it is it's compression of the vessels and the nerves, and that will cause them to faint. So some women actually feel very faint while they're pregnant. All right, gastrointestinal. 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 The appetite fluctuates. Your appetite fluctuates. Motility of the GI tract is decreased. Motility of the GI tract is decreased. So what does that cause? Constipation. Constipation's a problem. Heartburn's a problem. Hemorrhoids are a problem. Gallstones may form. And it's becoming, actually, we say we're in the kidney stone belt, but we're really also in the gallstone belt. We have a lot of gallbladder issues around here. Some of that is due to diet, some of it's due to weight. But women who get pregnant, I have seen a big increase in women who are pregnant and having gallbladder issues. If it is severe enough, they will take it out while they're pregnant, but they really want to wait. And so a lot of women you'll see coming in on surgical units that are 3 and 4 months postpartum that are having to have their gallbladder taken out. I did. That was one of the problems I had. But gallbladder is a problem. Women complain. We talked about the nose bleeding because of the increased congestion, and vessels are getting increased too, but the gums can bleed as well. So when they're brushing their teeth, their gums become spongy. Pregnant women's gums become spongy, and so they're very easily irritated to bleed.
Can something continue with your gums like after while you're breastfeeding? Like, is that
Shouldn't. All that should go away, but it takes away enough of that circulation to get back down to normal. Okay. If you've got a woman who's complaining of constipation during pregnancy, what is an easy thing to tell them to do to help relieve some of that constipation? Fiber and water. They need to increase their amount of fluids, like 3 liters a day is recommended. So increasing their fluids. All right, metabolism. Now, we talked about that a woman should really not gain much more than 25 pounds. If they're overweight going into pregnancy, they really closely monitor that. And sometimes some physicians will say, don't even gain the 25 pounds if you can. Now, that's very, of course, very difficult. You've got this baby already who's going to weigh 7 to 8 pounds on average, and then you've got the fluid and all that stuff. So you're going to gain some weight. Underweight women, or women who are too small, they, of course, they want them to gain more weight. Okay, so some other things along with nutrition and metabolism is we need to increase our protein, the amount of protein we eat, carbohydrates, and fats. Now, iron stores, a baby will have its own iron stores when it's born. However, it's not enough for it to last long. So increasing iron is a good thing too. And of course, that's one of the things that's in those prenatal vitamins is iron. So making sure they have iron, fats, proteins, carbohydrates. The endocrine system, the thyroid increases in size. The thyroid increases in size. And your metabolic rate increases. Now, the other thing under endocrine are those 4 hormones that we already have talked about. So I'm not going to go through them again, but just remember that they do deal with the endocrine system. Remember those, the HCG, the HCS, the estrogen, and the progesterone. Okay?
If you already have thyroid problems before you're pregnant, is that...
It can aggravate them. Sure can. They will have to closely monitor, and it depends on if it's hyperthyroidism or hypothyroidism too. But it can. If it increases it in size, it can set the thyroid storm off. You have to be real careful for that. Okay. All right. So that should be everything on your list. So doesn't it sound wonderful to get pregnant? Woo. And you know, a lot of women, you know, we go through all these things and it sounds horrible and we sound pitiful looking and, you know, very unattractive and all that stuff. But a lot of women, like Jennifer was saying, she had very easy pregnancies. I did too. I mean, honestly, I didn't have any of the nausea and vomiting and any of that stuff. I mean, I was teaching, of course, at the time, and I would keep goldfish. For some reason, I really wanted goldfish, so I would keep a bag of goldfish in my pocket, and I would just constantly just kind of snack on if I felt, you know, I was getting a little hungry or whatever. So a lot of women go through pregnancy and have no problems. So don't let it scare you thinking that you're going to look like a walking train wreck, you know, the whole time. Because a lot of women don't have any issues, or mild. Some of these things are mild. So, okay. Now, let's talk about how, and we mentioned this already. Remember, we talked about the 3 phases of adapting to a pregnancy. The first phase is that the mother has to be able to say, I am pregnant. Okay, so phase 1, I am pregnant. Phase 2, I'm going to have a baby. And then the 3rd phase is I'm going to be a mother. Have you ever known people who get stuck in one of these phases? Anybody ever have friends or relatives or know people who have trouble with these phases, getting through these phases? And again, we talked about all those reality shows, you know, that where they say, I didn't know I was pregnant till I walked in the, you know, and delivered that baby. Probably not. If you think about all the things that occur while we're pregnant, I doubt very seriously that happened. However, they may have psychologically or subconsciously suppressed those symptoms or those feelings. So more than likely that's what happened. It wasn't that they didn't know they were pregnant. It's just that Ms. Hyde and I have said that nobody else may use these trays but us, but we're sure getting ready. But anyway, you have to go through those phases in order for you to bond with your baby at the end. Now, how would a woman, what would be the best way for a woman to be able to accept the pregnancy? How would you help her to make that a reality? Ultrasound, a heartbeat, listen to a heartbeat. Shopping for the baby stuff, which is of course a fun, exciting thing. You know, going to Target or Babies R Us and using the whole gun and scanning everything. That's always exciting. But making her accept the pregnancy has to become a reality. It may be that she doesn't want to be pregnant or it was unexpected, but we still need her to be able to accept that she's pregnant in order for us to take care of that child. If you've got someone who can't make it even through that first phase where I am pregnant, those are the women who don't have the prenatal care. They may not make it to the physician's office. And those are the ones, too, who expose their children to those teratogens. You know, because they don't accept the fact that they're pregnant, they may be exposing them to things that they shouldn't expose them to. So not only are we trying to get the mother through that first phase, but it's important as well. The next thing that they have to do is to identify with the mother role, and that's hard for some people because they may not have had a mother figure in their life. If they were raised by their father or their mother just wasn't a good example of being a mother, okay, they may not have had that mother role in their life. So they need to practice the role. You know, you encourage them to babysit or keep somebody else's child, or going to classes, childbirth classes can help, or parenting classes. And you can go to those classes well before the baby's born. You don't have to wait till your baby is born to go to a parenting class. Some women as well, and we haven't mentioned this, you know, have you seen statistics, and I can't tell you a number or anything, but there's a lot of women who are waiting until their late 30s and 40s to have children. Because of what? Careers. Right, exactly, their careers. So not only may they not have wanted to get pregnant because they just didn't, it wasn't their time or whatever, but they may have a conflict with their career. Right, so identifying being a mother, trying to figure out how to be a mother and a career woman at the same time, and that might be a problem. Reordering their personal relationships, and what that means is they need to make sure that they have a good relationship with the father of the child. Now, that does not mean that they have to be happy together. They're not in a relationship, a long-term relationship where they're going to be together forever. Fine, but they need to at least be civil to each other. Have you ever seen people who have children together and they can't even talk? Some of you may have experienced that. And that's very difficult. That's a strain on the child, not just on those parents, but it's a strain on the child as well. So you really want to make sure that they work on that personal relationship. They want to be able to discuss their own feelings as well. There's fewer stressful moments in the pregnancy and having a new baby. And then they have to establish a relationship with the fetus. And we talked about that with ultrasound, hearing the heartbeat for the first time. There's a lot of things that you can buy online. I know that Keisha was talking about the other day about the music that you can have, and you can hook the speakers, or you can put the little speaker on on your belly and the baby listens to the music and all that stuff. There's all kinds of things you can do, but establishing a relationship with the fetus is very important. I think it becomes a reality, not only for the mother, but for the father, if they can when they see that ultrasound picture for the first time. Especially if it's a 4D ultrasound. You know, 3D ultrasounds and 2D ultrasounds, those old grainy photos, it's very, very difficult to tell that that's an actual baby and not, you know, an alien. But those 4D ultrasounds, those are pretty cool. And I've got Venas I'm going to play. I'm going to show y'all at some point. Where you actually can see Ben, they captured him, and he still does it to this day. He's almost 2 years old. When he is tired or when he's getting ready to go to sleep, he twirls his hair. He doesn't even realize. Huh?
Twirl his hair on the
Yes. On his 4D ultrasound, his hand is up in his head.
Oh.
So it's interesting. He still does that to this day. He still does that. He doesn't even know he's doing it. It's one of those unconscious things that he does. But in the 4D ultrasound, he has his hand, his head up to his head. That's what he's doing. So pretty neat. So you establish a relationship with the fetus, and then preparing for childbirth. And what would that be?
Nesting.
Nesting, yeah. But also, what can they go to? Okay, Lamaze classes, delivery classes, and we're going to talk about the difference between Lamaze and some other types of delivery methods. But different classes they can go to. What about those books? What to expect when you're expecting, or whatever they are. Yeah, the countdowns. You see those on Facebook all the time too. My baby is at week, whatever, it should be doing this. I have had students in the past who have asked to borrow these DVDs because they know somebody who's pregnant and they want them to see the growth of the fetus. I think it helps to know, even though you may not can feel them at 8 weeks or 10 weeks, what are they doing? What do they look like? What's going on? And if you've had your first ultrasound and everything looked okay, you're probably not going to have another ultrasound. And if you do, it's going to be later on. So you've got that time period where you can't really see the baby. So knowing what's going on and what they look like at the time can really help to prepare them and establish a relationship with that baby. Okay. The father has to go through the same types of things. Okay? Having a child is not just about the mother. The mother, I think, in some ways has it a little easier because they are able to actually feel the baby moving and see all these changes. The father can't really go through it. They don't experience that the way that we do. So, having the father accept the pregnancy is extremely important. It's a new status, it's a new role for them. Having them identify with the father role. If you've got a father who did not have a father around, or in some cases, their father was not a nurturer. Have you ever known people like that? Where their father was not a nurturer. Some of you may have had fathers that way. That they were a good provider, but that they weren't a nurturer. And that's a whole different ballgame. So identifying with that. Reordering their relationships, trying to get them to have a relationship with the mother. So it's the same type of behaviors, the same type of things that you want the mother to do. They can prepare for childbirth as well. There are books out there for fathers to be, and they can also go to childbirth classes. They're the labor coach. Guys in here who have children, what did y'all do?
I have a leg.
What about you, Jeff? Not even during the pregnancy or anything? Y'all go to classes?
Yeah, we went to a mom's class, and then a week later she was moved to the hospital.
First C-section, all that practice for nothing.
Yeah.
Did you read any books or anything?
We read books too. And we got the headphones and tried to play music and listen to the heartbeat.
No.
This thing really never worked. Listen to the
It's very hard to do.
I didn't know you could hear with a human ear like that.
Yeah, well, let's think about that though. She was like this big around whenever she got pregnant. I mean, that really only works if you had a very thin body going into it. I mean, women who have a little fluff on them like me. Doesn't work if you have fluff. Listening to the baby's heartbeat with the human ear. Remember in the video how he laid on her tummy and you can't do that if you're this big around when you get pregnant. It's good for the daddy because he can hear the heartbeat. You know, it's like did y'all ever feel the movement? Yeah, I mean the flipping and flopping. Don't shake your head. The flipping and flopping of the baby.
You don't think I don't have any running around?
Yeah.
Maybe floating. Maybe floating.
Okay, so, you know, sometimes, especially women who have very small, or their abdomens, their uterus is very close to their abdomen, a lot of fat going into it. You know, you can see the baby just kind of like wave form. You know, they're just like moving around and flipping them. You know, it's interesting to see. It's weird. Have y'all ever seen those pictures of the baby's footprint against the abdomen?
You can really see it like
Yeah, you can really do that. What? Amazing, y'all. Yeah, you are. They are. You're in that liquid, and it just floats around. There with them. It can, but it's loose. They can get out of it pretty easy until the water. Okay, enough about that. All right, let's talk about when they first come in. So they find out they're pregnant. They come into the hospital. The first thing they're going to do at the hospital is they are going to assess them and compare the record with what was going on at the office. So they're going to do an interview. They're going to ask them about their current pregnancy. They're going to ask them about their history, not only their OBGYN history, but their medical history as well. You want to know when you're going into a labor situation if they have any history of heart problems or diabetes or anything else. Drug use is very important to ask, and you'd be surprised, or you may not be, but a lot of women, when you just ask them flat out, do you do drugs? Will say yes. I mean, they're going to admit it to you. There are very few people that I have ever had that actually lied about it. They're very honest about it.
So we talking about
When they come into the hospital. Come into the hospital, yep. Because they're going to take the interview that they took in the doctor's office, and they're going to ask a lot of the same questions again. Sometimes those interviews, they're going to compare them. Yeah, this is prenatal. This is right before they come in. Yeah. I'm sorry. That's a confusing word. Okay. Yeah, and a lot of the stuff they have already asked. We talked about this already, right? We talked about a lot of this stuff already. The things that they're going to ask and want to know. They're going to do a physical exam. They're going to want to see what shape they're in when they come in. They're going to want to determine how far along that baby is. If a woman has come in labor and they're only 32 weeks, we want to try to stop that labor, because that's too soon. So they're going to do an exam and to determine if they are as far along as they think they are. And fundal height. You know, a lot of these facilities now are linked to the physician's office. Did y'all see that at the hospital? So that when they come in, they can actually pull up their records from the physician's office, which is good because what are you doing? You're comparing to see if anything has changed from the first visits or even the last time that they were at the office. They're going to pull up those lab tests. because they want to know. And you know, you could have a woman who they did the lab tests on at the very beginning, who tested negative for STDs, and all of a sudden now they tested positive. Those things change because they've had 9 months to play around. I mean, that was first or second month, you know. We got a lot of time here in between that they could have contracted something, the gonorrhea or the syphilis. Fundal height, like how tall, how big the uterus is.
Miss Ward, are there some things that, like with genital herpes, for instance, if you're not having an outbreak, you test negative for it?
No, you do always test positive for the virus. Yeah, because they're testing for the virus.
Oh, okay.
Yeah. Okay, so a lot of those things can change, and that's why they do a lot of this stuff again. They're going to want to check that rubella titer. Remember we talked about rubella is a vaccine, right? That's in what vaccine do you normally get in? Your MMR. And they're going to want to check to see if that's something they're going to have to give them before they send them home. Did anybody get to give vaccines the other day? Hep B. Did anybody give anything to a mom?
I got a depot shot.
You have a depot shot? Okay. So rubella is something. Are y'all looking? Y'all need to look for these things too. That rubella titer, see if they're rubella positive or negative. I mean, those things. And you want to not make sure that they don't get missed, because that's very, very important. RH factor. They're going to look to see what is their blood type, because remember, they're going to get RhoGAM during pregnancy, but they also have to get a dose after delivery of the baby. Everybody? Yeah, everybody. Everybody who's negative. Everybody who's negative. So if you come in and you're B negative or A negative or AB negative or O negative or whatever, then they will give you another shot within 72 hours after delivery. Nobody got to get RhoGAM?
Are we going to talk about the ABO?
We are. We're going to talk about that.
Because we had a baby with that.
Did
I
you?
had never heard. I didn't know anything about all that.
Yeah. Did she get a RhoGAM?
Not RhoGAM, because well, the baby had to go under the lipo. But Miss Chandler said that the ABO was not as bad as the RhoGAM, the negative blood types. The positive Coombs is what I'm talking about.
Okay, positive Coombs. All right, that was a little different. Yeah. So she was jaundice. The baby was jaundice.
I guess they're
Put
thinking
it
she
in
was
the line,
gone
the
at
Billy
the
light.
moment.
Yeah. We'll talk about that later on. Yeah. So you got to see that. That's good. That's not as common as the RH factor.
The Coombs positive as well.
That's good. That you got to see that. We'll talk about that later on. Okay, and then their follow-up visits. Did they make their follow-up visits? That's also going to tell us how they're going to do as a new mother. I admitted a child Sunday at the hospital. The baby was admitted with a temperature of 93. When he came in, his temperature was 93, near death. It took me forever to get him warmed up. He was 6 days old. And in the 6 days the child had been alive, first off, the mother had just recently gotten out of jail. The month before, she got pregnant in jail and had no prenatal care, apparently, that's what she said. She was positive for the gonorrhea. We didn't ask, but I think that they can have consequences, is what I've been told. That is a real thing. She had no prenatal care, and she was positive for the gonorrhea. And this was the saddest thing, and of course, knowing that she had no prenatal care would have set us up for this, should have been a big red flag. That in the 6 days the baby had been born, they had already been discharged from their pediatric practice for missing 3 appointments.
Oh, wow.
So, that's going to give you a clue on
Were they?
identity theft.
Oh, she was in trouble for it. Because I was going to ask if they spoke English. Like,
Oh, yes.
mine and Chelsea's patient was Hispanic, and she didn't have any prenatal. She didn't have anything till the day she came to the hospital. But I
How
did
scary is
see
that?
their identities, their license were from Mexico and everything. So I thought maybe they may be scared that they were going to
Yes,
be deported
and you
because
will
they're
see a
illegal
lot of that.
aliens, and that's why she didn't go.
You will see a lot of Hispanics afraid to come in for prenatal care because of the fact that they're afraid they're going to be deported.
She
Very,
didn't didn't know. She didn't know where
We
the
didn't know that.
pediatrician's office was at. She didn't know where the health department was to go back for her checkup.
This was baby number 3, and she's 24. So. I didn't understand that either. I couldn't know what it meant. Just tell me. Sweet baby. So anyway, but you see how that is a big red flag? So if you've got a patient who's admitted, like Coach was just saying, who had a prenatal care or who had been missing her appointments, you see how that's going to affect later on? Yeah, because if they're missing their pregnancy appointments, the chances that they're going to the doctor with that newborn are very slim. So you've really got to make sure that they're at least followed. Now that doesn't mean they're going to take the baby away from mama, but they might need to. But they're going to follow them they should follow them very, very closely.
Some cultures might not know that prenatal care because
Like this.
You will have a cultural thing too. This was definitely not a cultural thing.
but like South African prenatal.
Okay. They're also going to want to know what their birth plan is. Okay, what are you wanting to do? Is there a labor coach? Is the father going to be here, or is it a parent, or is it? Didn't y'all have a 14-year-old? Somebody had a 14-year-old delivered last week. Did somebody tell me they had a 14-year-old? I know we had a 14-year-old down at Northeast. 17. Yeah, we had a 14-year-old this weekend down there. So they're going to want to know if there's a parent there, or if there's a friend there, or are you wanting to have an epidural? Some people want to do it all natural, without an epidural. I don't understand that. Personally, I think God gave somebody the knowledge for an epidural, but some people want to do it all natural. 6 times.
6 times all natural. That's crazy.
4 all natural. Lunatics. And do they plan to breast or bottle feed? We need to know that ahead of time too. There's a big baby initiative right now where they want their hospitals are wanting these women, of course, to breastfeed. Now, I'm a big breastfeeding advocate. I think everybody should try, at least try. I know, I remember, and you're going to run into some problems. We're going to talk about this when we talk about breastfeeding with the family members. I know that my mother was just taken aback by the fact that I was going to breastfeed, because when I was a baby, that was not the norm. We were bottle fed, and so she didn't know what to do to help me, of course. But you're going to have some of that as well too. So a lot of teaching, a lot of education, but a lot of that stuff can start before the baby comes out. You've got a lot of time, that they're in labor. And so you can actually start talking to them about these things. What's going to happen? What are we going to do after the baby is born, and all that stuff. Okay, so you're comparing when they come in. You're comparing them to all these other visits. Have things changed? Are things about the same? Is the baby growing at the rate it should be growing? Okay. Now, during what you should see on a doctor's record is that they went monthly during the first and second trimesters, unless what? If they're high risk. If you've got somebody who had heart problems, or they're diabetic, or they're multiples, if you've got somebody who's pregnant with multiples, then they are going to go more frequently. But monthly during the first and second trimester, and then in the third trimester, they're going to increase bi-weekly and then weekly towards the end. Okay. Now, this is a picture. Well, we're going to talk about this in a minute. Let me see if that picture is on. Yeah. This picture, this prenatal care picture, is another picture that it has all the things that we've talked about this morning on it, the probable, presumptive signs, positive signs, all that stuff. So when you're looking at your PowerPoints, this is on there. Okay. Okie dokie. Let's talk about how you know how many pregnancies they've had. All right, now this can get a little confusing, so I really want you to pay attention. Did everybody see that sheet where it said GPTAL? What does that mean? Hopefully you did. Pull that out. GPTAL, what does that mean? I'm going to turn this off in just a second so I can put the screen up. All right, there's two terms that you really need to know. Gravity and parity. Gravity and parity. Okay? Gravity is pregnancy or being pregnant. The number of times that she's been pregnant. Okay? Gravity or gravida. So you'll hear nurses saying they're a gravida 2 or a gravida 3 or okay? The number of times she's been pregnant. Okay, so gravida. And then parity is the number of viable pregnancies or fetuses. Parity is the number of viable fetuses or pregnancies. So if I'm using the word viable, the rule of thumb is anything that is over 20 weeks. 20 weeks. Because at that point, now again, remember that the DVD talked about how even at 20 weeks, we're going to have a lot of problems. We're going to have a lot of problems. But the major organs are developed. Okay, so viable means a 20-week pregnancy, born dead or alive. Born dead or alive. So stillbirth does not affect parity. It does not. Right. If it's viable. If it's viable. Now I want you to change something on your PowerPoints for me, please. You've printed out your PowerPoints. Because the newest data says that the point of viability is 20 weeks. In your PowerPoint, I still have 22 to 24 weeks. You're gonna see, I just don't want anybody to email me or text me about this. You're gonna see some references are still gonna use 22 to 24 weeks as the point of viability. Okay, so we're gonna, for our purposes, we're gonna use 20 weeks because that's the newest research. Okay, again, those babies are gonna have a lot of issues. They're going to have a lot of problems. And there's still a lot of controversy. There's a lot of ethical controversies around about whether or not you should. And I used to, several years ago when I taught this, when I first started teaching this, we talked about, we would have a debate on whether or not you felt like you should resuscitate a baby of 20 weeks. You know, and there's a lot of ethical dilemmas out there about that. If you're, of course, the mother of that child, you're going to want everything done for that baby. Us as healthcare providers know, though, it's going to be a very long road. Very long road with a 20-month, with a 20-weeker. They are going to have a lot of issues, a lot of medical problems. So So a lot of ethical dilemmas out there about that. But for this purpose, we're going to use 20 weeks as our number. All right, now, there is a there's a two-digit description. Some hospitals only use G and P. So when they're describing and in your notes, did y'all see that when you were at the hospital? Okay. Some people just describe as G and P. So they'll say like they're a G3, P1 or whatever. Okay. That's all they use. There is a 5-digit system that I want you to know this. There's a 5-digit system that's a little bit more descriptive. It's a little bit more detailed, and that's what that GTPAL sheet is that I put out for you. Okay, the GTPAL, you've got gravida and para, but you also have T for term, P for preterm, A for abortion, and L for living. Okay, so you've got G, P, T, A. Oh, I went back. Hold on. In the GPTAL, this is taken out. Hold on. G. No, that's still wrong. Para changes meaning. Yeah, para changes meaning. It's GPTAL. GPTPAL. Yeah. Para changes meaning, and that's what they're talking about. Okay. All right, so T is term. That is the number of infants that is born after 37 weeks. Now, a lot of people consider 40 weeks as term, but technically 37 weeks, anything born 37 weeks or after, they count as a term pregnancy and delivery. Okay? P is premature. The number of premature infants born between 20 and 37 weeks. Okay, because remember, anything before 20 weeks is not considered what? Viable. Okay, it's not considered viable. So anything born prior to 20 weeks is counted under the A for abortion. And I believe I've mentioned this already one other time. The term abortion can also mean miscarriage. We think of it as an abortion, as they went in and had an abortion. That's not always the case. The actual term abortion means that they had a miscarriage as well. So it could be either or. They either did it was spontaneous or what they call therapeutic abortion prior to 20 weeks. And then L is the number of children currently living. Okay? All right, so, and I've got this note down there at the bottom. So if I asked you for gravida and para and nothing else, then I would want the number of pregnancies and the number of deliveries after 20 weeks. But if I asked you for the GTPAL, you would count each infant, not the deliveries. And that's a little bit confusing. Now, I want you to go back up on that GPTAL sheet and where it says para. You see, there's also a note up there. Multiple births count as one delivery, regardless of the number of infants delivered, because there was only one time that they went into labor. Okay? That's the number of, there's one delivery. Okay? I know it's very confusing. All right, so let's practice this. All right, you have a woman.
Two parents.
Okay? You have a woman who comes in, and we're just going to do GTPAL. Okay, we're going to take out this part for right now. We're going to do GTPAL. All right, you have a woman that comes in, and she is pregnant for the first time. Okay? So what is her gravida? 1. Her term, because we're taking parity out. Term 0, because she has not birthed that baby. She's only pregnant. Okay. Her preterm 0. Her abortions 0, and her living 0. Okay. She's pregnant for the first time, so she's G1, and everything else is 0. TPAL is 0. Okay. She carries the pregnancy to term, and the neonate survives. Okay. So now what is her gravida? 1. Her term is 1. Her preterm is 0. Her abortion is 0. And her L is 1. So far so good? Okay.
If you write out the letters, you have to put the 0 at the bottom of the letter, or so blank.
Well,
Blank means 0.
if you type, then sometimes it won't do it like that. You could put G1 like that, but it's supposed to be like G1 like that.
Yeah, like at the bottom. So
Yeah, it's supposed to put it the, yeah.
Okay.
Yeah. Okay. All right. She gets pregnant again. Okay, so she comes in, she's pregnant again. So what's her G now? 2. Her term is 1. Her preterm is 0, 0, 1. The second pregnancy ends in abortion at 18 weeks. Okay? So her G is 2. Okay? Her T is 1. Her P is 0. Her A is 1. And her L is 1. Okay. She gets pregnant again. She can't stop. She gets pregnant again, and she gives birth this time to preterm twins. Preterm twins. Now let's go back and look at our sheet. Okay? In a more detailed system, the GTPAL, what are we doing? We're counting each infant. If we were just doing gravida and para, if we're just doing 2, it's 1 delivery. But in this, we're counting all the infants separately. Okay? All right. Because we're not talking about deliveries at this point. We're talking about babies. Okay? Actual babies. Okay. So, she's pregnant again, and she gives birth to preterm twins. Okay? So, what's her G? 3. Okay? Because she's pregnant for the 3rd time. Her T is 1. Her P is 2. Okay. And her A is 1. And her L is 3. Okay. Let me clarify this one more time. If we were just doing G and P, her G and her P, her G would be 3. And P is now deliveries, not infants. So deliveries is 2. Okay? So para is deliveries. Okay? If you're using the 5-digit, we're talking about infants, babies. Each individual one separately. All right? Does that help? Clarify a little bit? Okay. Now, who has an exciting birth history?
I have a question.
Okay.
What would you consider an ectopic pregnancy when baby surgically do miscarriage?
Because you work on it, it develop into a fetus. Do you have an interesting work history? Me? Yeah. Yeah. Yeah, did you have a miscarriage? Anybody have any miscarriages? I hate to bring that up, but you've had a miscarriage and you have one living child? And a preemie. Let's do you. Okay, we're doing Laura. All right, Laura, tell us. So you have 2 children, 2 babies. Okay, so Laura has 2 children. One was term, and one was premature. At how many weeks? 30 weeks. And you had a miscarriage at what? How many weeks? Oh, baby. That's actually, for this purpose, I'm glad, because that's a good 26 weeks is past the point of viability. Okay. I'm sorry. Thank you for letting me use you. I'll give you a prize of some kind. Okay. All right. So what is Laura's gravida? 3, because she has been pregnant 3 times. Okay. What is her, if we were just doing the G and the P, what would her para be? Did you deliver your 26 week or not? You did. So what would it be? 3. Okay, everybody give Laura a hug after this. Number of term infants? 1. Number of preterm infants? Yeah, let's think about that, because remember, what did we talk about? Born between 20 and 30, because an abortion or a miscarriage is before 20 weeks, right? So what would her preterm be? 2. Abortion, 0. Living, 2. Do I see that? Okay. Let's use Teresa, because she has 25 children. Thank you, Laura. Thank you. You can write down your history now. You know your GPA. Okay. All right. All right, Teresa. 4 pregnancies. Okay. 4 pregnancies. You have 5 children. Were all of them term?
The twins were 35.5 weeks.
Okay. So they would be considered preemie. They would, because it's between, yeah, preterm. Right, it's between 20 and 37 weeks. All right, so 3 of them were term. 3 term children and 2 preemies. And 5 living. Yeah. Okay, so let's do Teresa. So her G is 4, right? Because she's got, well, now hold on. Yeah, the number of times she's been pregnant. Has everybody got that? I was confusing myself for a second. Okay. If we were just doing G and P, how many deliveries has she had? 4. Number of deliveries. You know, she didn't deliver one of the twins, go home, stop labor, come back in a week, right? Okay. The number of term infants, 3. The number of preterm infants, 2. The number of abortions or miscarriages, 0. The number of living children, 5. Anybody else have an interesting history? Holly's not here. You go through her 25 children. Anybody else have anything interesting? Anybody have a family member that was interesting?
My sister-in-law just had one of those molar pregnancies.
Oh, a molar pregnancy, yes. How far along was
I
she?
think like 8.
8 weeks?
It was like her first ultrasound, that's when they found out.
And that's when they found that one, yeah. So her 8 weeks, that would be considered before 20 weeks, so she would be under abortion. Yeah. Okay. So does everybody see this? Does everybody understand? If we're talking about just G and P, we're talking about parity. We're talking about deliveries. G is pregnancies. The P is deliveries. How many times they actually were rolled into the room and delivered a baby? Okay.
What case, or is it just a different hospital? When would they ask you all that detail?
The detailed stuff is they're going to, first off, they're going to ask you when you first go for your first visit. They're probably going to ask you again when you come in, just on your nursing history, on your admission history. They're going to ask you again. Look for this in your records when y'all go back to the hospital, and you can see. Now, the problem, though, is that you're not, even though we know this, you don't know specifics. So the specific details will have to be later on. Like with Hope's sister-in-law who had a molar pregnancy, that definitely is going to have to be documented, because what they do is they say they can't get pregnant for a whole year, and then because of risk for cancer. So they're definitely going to monitor that very closely.
Would that be hereditary at all? Because see, he's my half brother. His mom, which is my stepmom, had a molar pregnancy, and she developed choriocarcinoma after that baby.
Did she?
And so now when she had,
it is genetics.
So I didn't know if the father would have.
It is genetics, but there's also it also is. We're going to talk about the fact that 2 sperms fertilize 1 egg and all that kind of stuff. That the tendency for that to happen is genetically linked. Yeah. What were you going to say?
We are midway in. Ms. Chandler would say she's a gravida 2 and para 0.
Right.
But she had just had a baby, and we're like, why haven't they updated that?
Yeah.
Because she's like, well, now she's a P1.
Yeah.
I mean,
Yeah. A lot of times they don't update it, and they should. A lot of times they don't. And sometimes, even though it says GMP, they're still considering that P as something else. They're not, a lot of times they don't do it right. But according to your test, according to the way it is, GMP,
I thought she kept saying people were a mole tip, but is she saying multi?
she say multi, like multi.
Oh, okay.
Multi. The nullipara is the fancy term for never having, this is your first pregnancy. And a lot of people call them nullips.
Okay.
And multi, that's just that language. And you'll have to say,
It's prima or whatever?
yes, it's the same thing as a primipara.
Okay.
which is that's the first time.
Right. Yeah. You'll see nullips and multips, and a lot of, just remind her that you have no clue what she's talking about. Like a Q-tip or what. All right, so if I ask you on the test, if I say you've got this, 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 and this, you think you can do your GTPAL? After you practice? They just give you an idea of their obstetrical history. If you've got somebody who delivered preterm or who had a miscarriage, then it gives you a better idea of what they're at risk for later on. It's just a long, extensive way of getting their obstetrical history.
If the babies weren't around after PCCs, but they didn't live, that's still not considered
Because they were viable.
placement has to practice problems of this type.
No, I've never been able to find some, but what I've told people to do to practice is to go and do your family. Just do everybody's, like do yours. Were all of your 6 individual pregnancies all for term, so you're very boring. But but go find people that you know, and get their obstetrical history, like how many children do they have, how many were preemies, did they have any miscarriages, that kind of stuff. And you can make it up too. I mean, just make up a history. Make up a history. Just to give you some practice. You know? Yeah. Maybe everybody should write down their obstetrical history and we'll pass them out as examples. Yeah, we could do Vassiliev, whatever his name is. Obstetrical history. That would be. That poor woman, she was probably glad to die. Oh yeah, I know. That was pretty impressive. So, okay, let's take a break, and when you